My topic is patient positioning in anesthesia. Various goals, proper positioning in anesthesia are to provide best surgical access while minimizing potential risk to the patient, to promote proper physiological alignment, to provide comfort and safety to the patient, avoid pressure on chest cavity, to maintain circulation, to maintain airway pressure, and to prevent nerve damage. General considerations are the patient positioning during anesthesia care should be neutral one that would be well tolerated if patient were awake and unsedated. Weight-bearing surfaces and joints should be well padded and curvature including lumbar spine should be supported. Head should be in midline without substantial flexion and extension. Eyes should be closed without external pressure. Tilting of table should be done before draping. Using safety straps and prevention of falls from the table are fundamental. Remember, patient is not aware of the damage. So various positions used during surgeries are mainly supine position, lithotomy position, lateral position, prone position, and seating positions. So we'll see it one by one. Supine position is most commonly used position for surgeries. Head, neck, and spine all retain neutrality in this position. Arms can be adducted or abducted, but should be placed in as neutral position as possible. When adducted arms are securely placed next to the body, abducted arms are kept on boards beside the table. Attention should be given to pad bony prominences. These are the pressure points during supine position, mainly occiput area, scapula, olecranon process, thoracic vertebrae, sacrum, and calcaneus. So these areas should be padded properly. Extensive head rotation should be avoided. Extensive flexion or extension of head or extensive lateral rotation may put brachial plexus under traction. And in same, excessive abduction of upper limb should be avoided to prevent traction or stretch on brachial plexus. Forearm pronation of arm should be limited and padding should be done under the elbow to prevent ulnar nerve damage. It's the same padding under the arm boards should be done in supine position. This is how brachial plexus damage can occur in extensive abduction position. Various concerns during supine positions are mainly peripheral nerve injuries, mainly brachial plexus. If arm abduction is more than 90 degree, may cause stretch on brachial plexus. Radial and ulnar nerve compression can occur against bed or metal attachment. And lower limb peroneal and tibial nerve can damage due to crossing of feet and plantar flexion of ankle and feet. Vulnerable bony prominences due to sustained pressure. Backache can occur in patient because normal lordotic pressure often lost during GA with muscle relaxation or neuroaxial blockade. The lawn chair position is a modification of standard supine position. Patient's hip is at the break of table. So lower and upper halves of the body are slightly elevated in relationship to the hips. This position is better tolerated by patient, reduces stress on back, hips, and knees as they are in slightly flexed position. Abdominal wall tension also reduced in this position, and better venous drainage is seen in this position. It's a frog leg position. This position allows access to the perineum, medial thigh, and genitalia and rectum. Patient is positioned supine and then hips and knees are flexed with hips externally rotated and soles spacing each other. In this position, care must be taken to support the knees to minimize stress and postoperative pain in the hips and prevent dislocation. Trendelenburg position. This position frequently used to improve exposure during abdominal and laparoscopic surgeries. Various effects in this position are venous return increases, thus cardiac output and myocardial work increases. CBP also increases in this position. Also intracranial and intraocular pressure also increases. In this position, symphylated movement of abdominal viscera against diaphragm may lead to decreased functional reserve capacity, thus decreasing pulmonary compliance and increased pulmonary venous pressure. In spontaneously breathing patient, work of breathing increases in this position due to symphylated movements of abdominal viscera against diaphragm. And in mechanically ventilated patient, airway pressure must be kept on higher side to ensure adequate ventilation. Stiff head down position should be avoided. Reverse Trendelenburg position. This position used mainly to facilitate upper abdominal surgery by shifting the abdominal contents caudally. This position may cause systemic hypotension as venous return decreases. Position of head above the heart reduces perfusion pressure to the brain. Lithotomy position. This position most commonly used for generative urinary, gynecological, and colorectal procedures. There are various types of lithotomy position: standard, low lithotomy position, standard position, high lithotomy, hemilithotomy, in which only one leg is elevated, exaggerated, and tilted lithotomy positions. In exaggerated lithotomy position, extreme flexion at hip can damage sciatic or obturator nerve due to stretch, and direct pressure on femoral nerve can occur in this position due to extensive flexion. These are the same arms kept on side or near to the patient and are padded with adequate padding. In lithotomy position, this position requires positioning of lower extremities by two assistants to avoid torsion of lumbar spine. Both the legs should be raised together simultaneously, flexing at hip and knee. Lower extremities should be padded to prevent compression against the stirrups. And after surgery, patient must also be returned to the same position in same coordinated manner. Effects in lithotomy. In this position, pulling of blood from lower extremities to the heart occurs. So preload increases and thus transient increase in cardiac output and arterial blood pressure. Also, increased cerebral, venous, and intracranial pressure can occur. In this position, causes abdominal viscera to displace diaphragm in cephalad direction, causing a decrease in lung compliance and thus decrease in tidal volume. In many patients, can occur airway obstruction with obese or short neck patients. Calf compression may predispose to the venous thromboembolism and compartment syndrome. In this position, perfusion to the extremities inadequate, leading to the ischemia or edema. Various nerve injury which can occur in this position, mainly peroneal nerve, obturated nerve, common peroneal, and saphenous nerves due to pressure on bony prominences. Prone position. In this position, arms are abducted to less than 90 degrees. Chest and abdomen are supported away from the bed to minimize abdominal pressure to prevent pulmonary compliance. Soft head pillow has cutouts for eyes and nose. Breast and genitalia should be free from torsion. To promote low abdominal and thoracic pressure, multiple commercial rolls and bolsters are available. So in this prone position, bolsters are placed in such a way that abdominal should be free. Pressure in the axilla should be avoided to prevent compression of brachial plexus. Padding should be done under elbow to prevent damage of ulnar nerve. Extensive neck flexion should be avoided, and face should be kept in soft head ring with no pressure on eyes and nose. When GI is planned, the patient is first intubated on stretcher and a tube is well secured to prevent dislodgement of during positioning. Head and neck need to be carefully positioned to prevent excess pressure on nose and eyes. With the coordinated work with OT staff, the patient is turned prone on table, keeping the head in line with spine during the movement. Extra padded under forearm and elbow. Brachial plexus is at risk in this position, so ensure that chest support is not impinging into axilla. Arms may be tucked sideways on armboard or should be can be placed next to the head. Head supported face down or turned to the side, and extra padding should be kept under legs at hip and knee are should be in slightly flexed position. These are various pressure points during prone position, mainly cheek, ear, breast, genitalia, patella, and toes in lower limb. Various effects can occur in this position. Extensive pressure on abdomen can cause IVC compression, thus can cause reduced venous return and poor cardiac output. Respiratory system is better in this position, leads to the increased functional reserve capacity, and improved ventilation perfusion matching can improve oxygenation in this position. The prone jackknife position used for anal surgery is pilonidal sinus excision. In this position, patient placed prone with head and feet at slightly lower level. Chest roll are placed, raise the chest. Prone position, this Mayfield head holder position can be used for neurosurgeries or posterior cervical spine surgeries. In this position, head is supported without any direct pressure on face. These pins are firmly hold the head in one position that can be finely adjusted for optimal neurological and neurosurgical exposure. Rigid flexion is provided for cervical spine and posterior intracranial surgeries. An extreme head position may increase risk to the cervical cord injury in this position. So horseshoe headrest, in this position, forehead and molar regions allows excellent access are rested on headrest. In this position, we can see patient's eyes and face from lower side. The head height can be adjusted in this position according to the surgical requirement. The headrest is rigid and can cause trauma to the eyes or facial region in this position. Various complications in prone position that can occur are accidental extubation, obstruction of endotracheal tube, facial or airway edema. And in neck region, extensive lateral torsion or hyperflexion can cause postoperative pain, cervical nerve root, or vascular compressions. And visual loss can occur if any trauma to the ocular region. Lateral decubitus position. This surgery mainly used for surgery involving thorax, retroperitoneal structure, and hip. In this position, patient laterally rolled to the non-operative side. Lower legs is flexed with padding between the legs, and both the arms are supported and padded. Dependent ear should be checked frequently to avoid folding and undue pressure. Eyes should be securely taped closed before repositioning and frequently checked for compression. Same seen in this photo. Padding placed under both the arms and a roll placed under chest. Axilla should be kept free. Elbow padding done under lower legs. Lower leg is slightly flexed. So in lateral position, patient rests on non-operative side and is well balanced with anterior and posterior support. Patient head must be kept in neutral position to prevent excessive lateral position, to prevent excessive rotation of neck and stretch injury to the brachial plexus. Eyes should be securely taped and closed, frequently checked for compression. In prone position, chest roll is placed to support to the thorax. And in this position, dependent lung is underventilated but overperfused, and non-dependent lung is overventilated but underperfused. Venous hypertension can occur in dependent arm due to venous outflow obstruction. It's the same. To avoid compression of dependent brachial plexus or blood vessel, axillary roll is placed between the chest wall and the bed. And pulse should be monitored frequently in dependent arm for early detection of any neurovascular compressions. To flex lateral decubitus position, patient can be flexed in lateral position to spread ribs during thoracotomies or to improve exposure of retroperitoneum in renal surgeries. Point of flexion of patient should lie under the iliac crest rather than under the flap or lower ribs to prevent ventilation of to optimize ventilation of dependent lung. Seating position. This position mainly preferred for posterior cervical spine or posterior fossa surgeries. Head may be flexed with pins or taped with adequate support. Arm must be supported to prevent shoulder traction and stretching of brachial plexus. Knees are slightly flexed for balance and to reduce stretching. The legs are kept as high as possible to promote venous return. Position produces excellent surgical exposure, can cause decreased blood in the operating field, and superior access to the airway. We can handle airways open for if anything occurs. We can have access to the airway. Bench chair position used for mainly shoulder surgeries, including orthoscopic procedures. Arm must be supported to prevent stretching of brachial plexus. In this position, associated with the risk of cerebral underperfusion because decreased venous return and decreased cardiac output. So blood pressure should be maintained in this position. Same sitting position, venous return decrease and decreased cardiac output. So hypotension can occur. Overall ventilation is good in this sitting position. Same in sitting position, pulling of blood in lower body. So patient may prone to the hypotensive episodes. Extensive cervical flexion can impede arterial and venous blood flow, causing hypoperfusion and venous congestion of the brain. Because of the elevation of surgical field above the heart and inability of dura venous sinuses to collapse because of their bony attachment, the risk of venous air embolism is higher in sitting position. Various complications are same: hypotension, venous air embolism, airway obstruction, obstruction of neck veins in extensive neck flexion, and pneumocephalus. So Watson-Jones ortho table used for femur surgeries in orthopedic surgeries. In this position also, lower extremity compartment syndrome and nerve injuries can occur in long surgeries and compression over pressure areas. Physiological changes related to the changes in body position mainly are related due to gravitational effect on respiratory and cardiovascular system. Any alternation in position can cause redistribution of blood within the venous, arterial, and pulmonary vasculature. So all the changes are related with this during reposition of patient. Overall peripheral nerve injuries during positioning of patient, mainly overall mechanism is due to stretch, compression, generalized edema, or metabolic derangement. Ulnar nerve injury is most common injury, often occurred when ulnar nerve is compressed between posterior aspect of medial epicondyle of the elbow and arm board or paid, most likely with elbow flexed or forearm pronated. Symptoms of ulnar nerve injury include inability to abduct or oppose fifth finger, little finger, or diminished sensation in fourth and fifth finger, and eventually atrophy of intrinsic muscle of hands, creating claw-like hand. A recommendation to prevent ulnar nerve injury is to avoid extensive pressure on posterior condylar groove of humerus. Flexion may cause injury to the ulnar nerve. Prolonged pressure on spiral groove should be avoided. Extension of elbow may stretch median nerve. Keep the hand and forearm under supinated and in neutral position. And abduction of arm should be between 30 to 90 degree. Next common is brachial plexus injury. Injury occurs often when plexus is stretched or compressed between the clavicle and first rib because of the proximity and mobility of both clavicle and humerus. It is can associated with the lumbar position when shoulder braces are placed to the patient and Trendelenburg position is given, so can cause traction or compression over brachial plexus. Recommendation to prevent brachial plexus injuries: to avoid extensive lateral rotation of head either in supine or prone position. Limit abduction of arm less than 90 degrees in supine position, and while giving stiff head down position, shoulder braces should be avoided. When possible, use non-sliding mattresses. Next are the ocular injuries. Main causes are pressure effect on globe or direct trauma, chemical irritation from pre-op solution, and intra-op hypotension. Various ocular injuries are corneal abrasions, periorbital or conjunctival edema, ocular hemorrhages, vitreous loss, retinal detachment, or ischemic optic neuropathy. So, to prevent perioperative eye injury, early and careful taping of eyelid after induction of anesthesia should be done. Any dangling objects should be watched. Avoid direct pressure on eye to prevent retinal artery occlusion. Frequently, eyes are checked and documented when patients in prone position, and post-operative evaluation of vision should be done. So this is a repositioning checklist. Whenever any change in the position, we should check for these points, mainly airway to check endotracheal tube or LMA. Breathing should be checked to ensure adequate ventilation. Auscultation should be done, and monitoring of saturation and capnograph. Any changes in this should early diagnose if any complications are there. Circulation by monitoring heart rate, BP, and ECG. Intravascular lines should be checked. Are they are in situ and properly working? Eyes should be checked, and neurovascular should be checked by seeing adequate padding under vulnerable bony prominences, and all cable catheters electrode should be checked whether they are in proper position or not. So this is the repositioning checklist we should check during after the changing of patient position. Don't forget, good positioning start with assessment. Prevent surgical team from leaning on patient. Armboard pad should be at the level of table. Cushioning of all pressure point is priority. Access extremities at regular interval for signs of circulatory compromise. Documentation of position should be done every time. And remember, anesthetized patient can't make other aware of compromised position. So we have to take care of itself. In the end, comfortable position is important. Uncomfortable position make patient uncomfortable and may lead to the complication. And few cooperative patient may not complain in uncomfortable position. Thank you.